Welcome everyone to another episode of Endocast, where we discuss real clinical challenges in modern endodontics. I am Dr. Ahmed Shauki, and
And I am Dr. Francesca Cerutti. Today we are discussing one of the most feared complications in endodontics, the sodium hypochlorite accident.
every endodontist has thought about it. What if it happened during my treatment? Although fortunately uncommon, when it occurs, it can be dramatic for both the patient and the clinician.
Yeah, the good news is that most accidents are preventable, and even if they occur, an early recognition and systematic management can dramatically improve the outcome. And today we will be focusing on three questions. First, why does it happen? Second, how do we recognize it? And third, what should we do immediately?
Exactly. So, in our first part of this podcast, an important podcast, by the way, the most common cause is the improper irrigation technique. The issue is usually the pressure rather than the irrigant itself. If the needle binds inside the root canal while irrigation, there is no passive backflow, and pressure forces the irrigant outside the tooth beyond the apex. Always ask yourself, can the irrigant flow back coronally or not? If it cannot backflow, so you have to stop.
Exactly. And second, another risk factor can be the presence of perforations or over preparation. So we have a very wide foramen because we prepared a bit too much, or we have a wide foramen because of apical resorption, or we have a wide foramen because the tooth is immature and so the apex is open. And other predisposing factors are the position of the tooth relative to the alveolar bone. So there is maybe a very thin cortical layer or a fenestration of the cortical bone. And also remember who gets this kind of accident most of the time. Most of the time we're speaking about women in their mid age, and so why? Because of the bone density. Even this part can be interesting. Try to set your mind on the patient that you're treating.
I think now I can feel lucky about that fifth point about the bone density and the gender of the patient. So, being a male patient, if I had to do a root canal treatment, I'm lucky now. Now we are moving to another important part in this discussion about recognizing the accident, recognizing the sodium hypochlorite extrusion accident. So the first sign is usually sudden severe burning pain followed by rapid on-site swelling. So the patients may report that the taste or the smell of a bleach. Sometimes they can report epistaxis, which is bleeding from the nose, or altered sensation involving the infraorbital or mental nerve according to the location of the accident. So we have to stop the treatment immediately if the patient reported these incidents.
Yeah, also because if we do not stop immediately, the dissolution of organic matters and hemolysis caused by the sodium hypochlorite make it spread to the tissues, resulting in diffuse ecchymosis.
That's right. And after recognizing the accident, we have to profoundly assess the clinical situation. So the clinical assessment after recognizing the accident is very important for the treatment plan that you are going to handle, by which you are going to handle the accident. So we have to assess facial swellings systematically using bilateral facial landmarks, measurement of the distances between six facial planes from the tragus and mandibular angle, which can be compared with the opposite side to determine the extent of the swelling. This will also help in the follow-up of the patient after management of the accident.
And then, after evaluating facial swelling, try to evaluate the airways, breathing and swallowing first. And then go and check for sensory or motor defects. So, check the function of cranial nerves, and then also the intraoral examination. Look for swelling or ecchymosis or ulceration or necrosis of the tissues, and document all the findings carefully. Try to keep your cool and take some pictures or some small video, even with a mobile phone, in order for you to be able to compare the initial status to the status of the healing when you will be following up the patient.
Now we are moving to the core of this discussion, which is the management of the accident. So, first of all, we need to assess the severity of the accident, so that the first step in the management is the assessment of how severe is the sodium hypochlorite accident. And the sodium hypochlorite accident can be mild, moderate, or severe depending on the degree of pain reported by the patient upon happening, and the swelling extent, as well as soft tissue findings like the ecchymosis, like the ulceration, necrosis, etc.
Exactly. And so when we have to treat, we also have to understand the timing of the treatment, because there will be something we are going to do immediately, that means within the first 24 hours, and then early treatment within 1 week, and then delayed, so long term treatment or follow up of the case. So, how do we manage a mild injury? We define a mild injury an injury in which the patient in a pain visual score reports a pain ranging from 0 to 3. Swelling is less than 30%. There is a localized ecchymosis, but no ulceration, no necrosis. So, this is something that we can manage by ourselves as GPs or as endodontists. What do we have to do immediately? We have to irrigate the canals with water or saline, with the aim of diluting the sodium hypochlorite. We want to decrease the concentration of the sodium hypochlorite. And then we can provide some over the counter analgesia. This should be enough to manage the symptoms, because we are speaking about a low degree of pain and a low degree of damage that occurred to the patient. And we can also prescribe some non-steroidal anti-inflammatory drugs, and in the beginning some cold compress in order to reduce the swelling. And we can take an X-ray in order to try to identify the cause for the extrusion injury. So, perforation, wide foramen, why did it happen? And then, last but not least, we could leave just the canals open to drain, but if we do so, we have to daily see the patient in the next days in order to check on it. Yeah, then we can follow up the patient in the first week and suggest him to do some compression with some warm towels in order to stimulate the local circulation. And if we see that the tooth cannot be restored for some reason, maybe it broke, extract the tooth, don't wait. And then regularly review the patient to reassure him and to just monitor the symptoms and the evolution of the disease. And the late treatment is to if I can complete the root canal treatment, then I finish it. And maybe I will be using some irrigant different from sodium hypochlorite in order not to have the same problem a second time.
So that was really comprehensive about the mild injuries. But on the other hand, if we have moderate injuries, are these are presented as pain on the scale of 4 to 6 on a visual analog scale, and the swelling can be 30 to 50% more than the unaltered normal side, the opposite side, with diffuse ecchymosis and intraoral ulceration. Moderate injuries required specialist assessment in the first place, imaging, and management of the soft tissue injuries. The early management is the same as the mild injuries, in addition to debridement of the soft tissue ulceration and necrotic tissue, because in mild injuries we have soft tissue lesion due to extrusion, so you need to just debride and clean all these ulceration or necrotic tissues. The early management is the same as the mild injuries, in addition to particular step which is debridement of the soft tissue ulceration and necrotic areas, because there are some soft tissue loss due to extrusion of the hypochlorite into the soft tissue, so you have to clean that. Late management involves replacement of the lost tissue, which is mostly adipose tissues, using dermal fillers, for example, for correction of any possible, because this is not the case in every extrusion or every moderate injury due to sodium hypochlorite accident, but sometimes we have some soft tissue loss that can be replaced with using dermal fillers to avoid any permanent facial deformities. And of course, this should be performed by a trained and experienced oral and maxillofacial specialist.
And what about the severe injury? So we are speaking about something where the pain of the patient is higher than 7 and the swelling is more than 50% if compared to the other side of the face. We have diffuse ecchymosis and also we have intraoral ulceration, necrosis, maybe also the airways are compromised and there is a neurovascular deficit. Of course, in this case, we cannot manage it by ourselves. So we have to immediately refer the patient to the hospital and to a specialized maxillofacial unit. So immediate treatment involves first urgent referral to the local OMFS unit. Second, opioid or intravenous steroids in order to aid with the inflammation. And also, we should be considering intravenous antibiotics in order to reduce the risk for a secondary infection, because here there is a huge damage to the tissues. And we can also need an MRI in order to identify which tissues are inflamed or a CBCT in order to assess the effect on the surrounding tissues. The early treatment is the same as the mild injury, so nothing particular. Maybe there is need to drain any collection which might have formed, so this is the big difference. And of course, we need to have the patient reviewed regularly, but this will be managed by the oral and maxillofacial surgeon. The late treatment of this kind of disease is same technique as before, so we will be needing to correct any soft tissue defect by fat transplant or fillers or prosthetics in general. And if there is any sensory or motor neurovascular deficit, we will need to be reviewing the patient regularly, and maybe there will be need for some treatment. And there could also be some neuropathic pain following this kind of accident, and so there will be the need for a specialist to give some pharmacological treatment in order to address this specific problem. And then The patient who could also be needing some speech therapy or language therapy in order to rehabilitate the speech and the swallowing functions.
But now I have one question for you, and because you are experienced in that topic, which is, what if the clinician face some extrusion of the sodium hypochlorite into the sinus accidentally?
Okay. Well, this is a topic that is very interesting for me, but it has been reported in the literature sometimes. And we always have to consider the amount of sodium hypochlorite that is extruded into the sinus, because probably every single endodontic at some point in his life extruded some sodium hypochlorite somewhere, and maybe a part of this sodium hypochlorite went into the sinus, but without probably major damages because it was immediately recognized. Okay. In this case, we have uh, Erich and colleagues that reported a case of an endodontic therapy of a maxillary right first molar, and shortly after irrigation of the palatal canal with full strength 5.25% sodium hypochlorite, the patient complained about having a taste in his throat despite the presence of a correct rubber dam isolation. And so they irrigated the canal with sterile water, and they found that the water was passing through the palatal canal into the maxillary sinus and onto the nasal cavity via the osteomantry and then into the pharynx. So, apart from the initial congestion and the mild burning sensation in the right maxilla, the patient experienced no severe consequence and was asymptomatic 4 days after the accident. In this case, there was no major consequence, but we will have a full discussion soon on this topic about the endo-sinus communication in the endocast, so stay tuned. And then we have another case of a right second premolar where they used a lower concentration of sodium hypochlorite, 2.5%, and even in this case, the patient had immediate burning sensation, but in this case, there were also nasal bleeding, and the patient complained about swallowing blood and not being able to breathe correctly. So, of course, they immediately stopped the irrigation. They irrigated with canal with sterile saline, dried with sterile pepper points, but 4 days later, the root canal treatment was completed with no complication, and after 3 months, the tooth was asymptomatic. The last case reported in the literature, for what I know, is about a maxillary right second premolar. And also, in this case, during the irrigation, the patient had severe facial pain and swelling. And in this specific case, the patient had to undergo a Caldwell-Luke approach. So they had to drain surgically the sinus. And despite an apparent healing of the sinusitis, the tooth remained painful, and so it was extracted in the end, 3 months after the initial presentation of the symptoms. So it can change a lot from case to case, but what really makes the difference is how much sodium hypochlorite we extrude into the sinus in this case before noticing, and so according to the amount of the damage there will be a very different outcome of this teeth. And this is my sodium hypochlorite accident into the sinus. So I was retreating the first molar of this patient, isolation, disassembling, I removed everything, I found the MB2, I was doing everything, but I had some large foramina in this case because my shaping was higher than 50 ISO, okay? And while doing the final irrigation, I had some blood coming out of the canals, and the patient was bringing his hands to the area of the sinus, and I was like, okay, are you in pain? And he was like, it's the strongest pain I've ever felt in my life. So immediately, irrigation with water. I put nothing as a medication into the root canal. I just temporized. I gave him painkillers, immediate application of cold, and then I told me use some warm compress and stuff, and I made him be reviewed during the following week. 7 days later, I was able to finish my root canal treatment with no complication, and then the tooth was restored and protesized. So it ended up well.
So, from all these cases, we can conclude that it can happen with the most experienced clinicians because it depends on the anatomy, the amount of sodium hypochlorite, the foramen, and the relation between the roots and the sinus. So, that accident doesn't mean that the clinician is not controlling the procedure, but it is called an accident. That's why we have to just reassure the patient at the first happening of this accident, and then we follow the recommendation about the management as we just discussed. So now we are going to discuss the prevention, and it goes without saying that we have to use a side vented needle. Never bind the needle into the root canal. Irrigate slowly. Keep agitating the needle up and down, and maintain the continuous backflow of the irrigation out of the canal in a coronal direction. And this is very easy because we have the same physical action of the fluids coming from the narrowest part to the widest part of the root canal.
Yeah, exactly. And remember that successful irrigation depends on the controlled exchange, not on the pressure. And that's why we can use negative pressure irrigation. Look at this case. Here I'm doing the treatment in this tooth. You see that I'm checking with the Valsalva maneuver if there is a communication between the tooth and the sinus. And there is. So in this case, I cannot use anything different from negative pressure irrigation. Otherwise, when the patient breathes, is going to inhale the sodium hypochlorite. And so, of course, this can be a tool that is extremely useful, above all in these cases. So when we think that there could be a communication with the sinus, always use negative pressure irrigation because it's the safest way to deliver sodium hypochlorite and to prevent the accident from happening.
So I think we have been so serious, not like every time, a lot of humor. This time we were serious because this is a serious accident that can happen in our practice to all of us. So I hope you had some guides in order to manage and before that to recognize the accident. So sodium hypochlorite by itself or sodium hypochlorite per se is not a dangerous solution. The uncontrolled pressure is the dangerous part, not the solution. So you have to control your pressure. If you cannot use some devices like the negative pressure, side vented needles, and all the tools that we have mentioned in our discussion.
Yeah, because the proper tools and the proper techniques, together with some awareness of the anatomical relationship between the teeth and the other structures, can really help us prevent most of the accidents.
So I think we ended a very important episode in the season, and see you soon in a very interesting episode, the next one. So thank you for joining us in this episode of Endocast.
Stay curious, stay conservative, and keep on saving teeth. See you in the next episode.
Ciao.